series on rotator cuff pathology. Now, the cool part about rotator cuff pathology is this is a continuum. So I've learned from Neer is that 100% of people that have impingement syndrome also have symptoms and signs associated with scapular dyskinesis. Of that, 95% of people with impingement syndrome have resultant rotator cuff tendinopathies. So what we can see is that this is a continuum. Once you have one, then it can lead into the next one, lead into the next one. Now, there's, of course, traumas built into that. And then, of course, that's based on literature and evidence and observations from the 1970s. So I really think that one does not cause the other. You don't have A plus B plus C equals D. Instead, all these things are happening at the same time. It would be foolish of us to say that somebody has just rotator cuff syndrome, because what we see is that when somebody has issues with their rotator cuff, meaning isolated lesions, as identified on an MRI or some other kind of imaging, we also see what else? We can see slap problems. We can see issues with impingement syndrome, positive Hawkins-Kennedy and Neer Test. We can have a plethora of other issues going on in the shoulder. The real question is, which tissue is provocative of pain, meaning which tissue is currently causing that person's symptoms, because that's why the patients come in to see us. Yes, we need to have an isolated lesion so we can identify what's wrong with the person and have a clear understanding of how to treat that person. However, we also need to understand that all these things are happening at the same time, that really that person coming in that's 50 years old, they could have any number of things as far as rotator cuff tears, partial and full thickness. They can have slap lesions, they can have degeneration, they can have a type 3 acromion. We can't say which one of those, based on the imaging, is a source of pain. That's when we're going to use imaging, we're going to use a history, and we're also going to use our orthopedic exam to identify that tissue. Now, let me make one thing clear. The purpose why we're doing that is because it makes all the difference. If you have somebody that has a rotator cuff problem, and let's say it just happened, it just started, and they've never had this kind of pain before, chances are that's an acute injury, it's an inflammatory type pain, it's a chemical type pain. We need to rest, relax, ultrasound ice, and give this person a break from whatever activity they were doing. Let's say they went to their wife bought a bunch of cabinetry from IKEA. Well, when they're putting together all that furniture, constantly twisting and lifting, do they cause some shoulder pain? That's not that big of a deal. I'm going to be nice to that patient. Let's take that same patient, however, instead they have a chronic, dull, achy pain in their shoulder that gets severe when they go to pick their arm up, and it's been going on for 5 years, and they used to play college baseball. Chances are that's not an acute tendonitis. Chances are that's more of a tendinosis or a degenerative model of a diagnosis that we need to treat appropriately, because that type of diagnosis needs to be roughed up and treated and stretched and strengthened. And so we really have a different mode of care dependent on that demographic of patient and also the tissue origin. So rotator cuff pathology is really two things. The first, identifying which is the problem as far as which muscle, and we'll go over that, of course, in this class, and then also determine the best course of action. Sometimes it's being nice, sometimes it's roughing up that tissue a little bit. When I was in school, this is what I learned, and this was what in my brain, I thought the way that most tissues worked in our bodies, we had an insult. We had some kind of energy, potential energy that was delivered into our system, and we had to absorb that energy, and what we had was two options. The first, that energy was enough, then it resulted in a tear, a break, some kind of tissue injury. It breaks the tissue integrity, tears the cartilage. Or you just damage that tissue, stretch it a little too far, and you get some inflammation and you get some healing. And while there is some validity in that, I would challenge each and every one of you to continually think about the same questions differently. And this is a story that I heard about Albert Einstein that I think is powerful in many aspects of life, but definitely in the musculoskeletal arena. As it turns out, after giving a final exam to his students, Albert Einstein was walking out with the assistant professor, and the professor leans over and says, "Professor Einstein, that was the same test that you gave last semester." And he said, "I know," and kept on walking. A couple steps go past, and the professor said, "Well, that's Okay, but that was also the same students that you gave the same test to last semester. And he said, I know. And the professor said, well, what's the benefit of giving the exact same students the exact same questions? And Einstein says, I understand that that was the exact same amount of students and the exact same questions. However, the answers have changed. And that is what I want to infer or really get across in this lecture, is that we really can, with the ability to talk with mentors, with new emerging research, to get a better idea of what's going on with these patients and to get a better idea on how to treat these patients. Because if we treat patients the same way that Codman looked at the shoulder or Neer evaluated and treated shoulder, we would be incorrect. By no means am I taking anything away from those pioneers in shoulder research and shoulder surgeries and treatments. However, we know more than we knew 10 years ago. And so if we can keep up to date with the new information, when the same patient comes in, we can actually give them different answers to the same problem based on new and emerging research. So I really would like to focus more on tendinopathy, but as we know, tendinopathy could really be divided in two sections. A tendinitis, which is more a chemical inflammation. Something's been torn, your body's going through an inflammatory reaction. Or you have a tendinosis, and that's when you've had repetitive insults to those muscles, tendons, joints, and now you start to see that tendon is starting to degenerate. It's starting to lay down calcium. There is no more inflammatory reaction, and that's a big difference because the treatments that we're going to do for a tendinitis are vastly different and counterintuitive, in fact, to a tendinosis. So it's our job as clinicians to look at how the patient presents, coupled with their physical exam, so we can have an idea on how to treat this patient effectively. Because when some people may need to suppress inflammation, other people may need to enhance their inflammation to bring upon that healing potential to that area. So when we look at the shoulder, as we're doing for this class, we really need to focus on a couple things that can injure a tissue, and sometimes, just as important, things that can limit healing. So when we look at the supraspinatus, which just happens to be the most common tendon that's involved as far as a rotator cuff, tendinopathy, because of its location, not because of too many other respects, but it does take the brunt end of tensile and compressive forces upon arm abduction and flexion. So this muscle just takes the brunt end of it. It has nothing to do with, nothing personal against the supraspinatus, but unfortunately it's got a really hard roof on top and it's got a humerus on bottom and it gets pinched a lot. And we talked about that in the anterior impingement lecture. However, now we're going to go into exactly how this happens. So as it turns out, when we look at most tears within the supraspinatus, most tears actually happen on the articular surface, just about 1 centimeter proximal to the insertion on the humerus. So they happen in this area, and that's a big problem because we need those tendons to be strong. We need those tendons to be able to abduct and forward flex the arm. Now, when you have these tears, they happen on the articular surface and not on the bursal surface. And the bursal surface is where most people think they have a rotator cuff problem because they've been educated and they've gone on Google and they learned about these big nasty hooks and spurs that hang off their acromion that are causing it to dig into these tendons and cause tears. And what we know is that's not true. In fact, it's just based on tension and compression. We're going to get the most amount of tension on this muscle or on this part of the muscle and tendon unit when the arm is in an abducted position, and the most amount of compression on the articular side when it is down and it's down in lower areas. And even more so, we're going to get most compression when you're laying on it or you have sustained arm elevation. So we see these patients come in and they keep on injuring themselves because of maybe picking up buckets or painting a ceiling, where you're getting that constant compression to the supraspinatus, and then they're going home and sleeping on it and further limiting the amount of healing potential, or essentially blood due to ischemia and laying on it, and it's not allowing that tissue to heal. So if we have a tendinosis, we need to find ways to actually strengthen that tissue. We need to find ways to limit the amount of compression, increase the amount of blood flow to the area, and we're going to select treatments and positions and postures and sports and activities based upon those that paradigm. And if we use the right methods to increase inflammation and to strengthen that tendon, then we can keep that person out of pain. If someone has more of a tendinitis, the last thing I want to do is to go in and force some more inflammation, to use an instrument-assisted manipulation, to rub a dull screwdriver on it, to give them eccentric exercises. That would actually be counterintuitive. So we really want to focus on how does the patient present, what do we think is wrong with that tissue, and then going about using the right type of methods to alleviate those symptoms. Here's a slide to really hammer that home, is more your itises are an acute type situation. It just happened. It's never happened before. An acute amount of stretch or strain or overload that wasn't there before. Maybe they were sandbagging the week before. Maybe they started a new workout. That would be more of a tendinitis. Once we hit the period where this has been going on for a couple of weeks, now we're leaning on more of a tendinopathy, where this has been chronic. It's just not healing. We have compressive overload and ischemia to that area, not letting it heal. So whereas tendinitis looks at more, you have too much inflammation. Tendinosis is you've kind of avoided treating this. Your body's just given up. It tried to heal that area, but it's just not working. So we have a failed inflammatory reaction. So we need to do treatments that actually increase inflammation to that area. So very different treatment paradigms, even though the patient may have the exact same symptoms. Now, I highly recommend looking at information based on when a patient presents, whether it's a chemical inflammation versus a mechanical inflammation. I'm sorry, a mechanical pain versus a chemical pain. Chemical pains, more of our itises, if you have inflammation and you have a bathing of the tissue with your pro-inflammatory cytokines, it's going to be constantly sensitive and irritated, and it could possibly be swollen. A tendinopathy is not going to have that. Instead, they're only going to have pain once you add compression to that injured tissue, or once you add tensile strength. So a typical tendinosis type patient, their shoulder feels just fine down here. Move it around, yeah, I'm perfectly fine. It's not until you go to get the jug of milk out of the refrigerator and you put a little bit of eccentric stress on that shoulder that they feel that sharp pain. But then you put the milk down and it's gone. And itis, once you use it, it's going to be irritated, it's going to be swollen, it's going to be throbbing. But both of these are localized pains. They're not radicular symptoms. They're not peripheralizing at all. So these are isolated musculoskeletal type pains that are not following a typical pathway of a nerve root. Now, when it gets into the treatment, we're going to cover a couple things as far as the treatment, meaning if you have an itis, we're going to be nice to it. If you have an osis, we really need to rough it up. There is a lot of debate on what are the best types of exercises, and we've done our research, and I can tell you right now, it just depends. It turns out that just putting tensile stretch and putting load across a musculoskeletal unit, similar to Wolff's Law in the bones, is you need to just constantly load that tissue. If you load it across a full range of motion, you can increase the strength of that tissue. If you had to do it in a quick amount of time, eccentric tends to be a little bit faster as far as building strength, but it's really about loading that tissue. I find that most of my patients are going to have a certain arc of pain, meaning they can pick their arm up right there, and then it kind of goes away. And that's because that as you pull on a muscle, as you're going through a range of motion within a joint, you're going to pull at that muscle, all the different fascicles at different amounts of strain based on your range of motion. So just because they have pain and then it goes away, they could still have a tendinosis in one specific part of that supraspinatus in this case. I usually start with more of an isometric exercise to get the pain to go away. In fact, there's a ton of research with patellofemoral pain syndrome, or patellotendinosis, of doing a decline squat. Just going right into that area of pain and holding it there. You're putting tensile stretch across only those fascicles, only those units that are damaged, and it can help strengthen that tissue and also relieve pain. But when it comes to the shoulder, eccentric exercises tend to give you the biggest amounts of strength gains in the shortest amount of time. As far as strength, this is one of those things that I find more with my female patients. They get really worked up about strength. The shoulder, but also mostly in the hip area. I don't want to get a big butt. Well, that's just not going to happen, especially in the first 4 weeks of treatment. The first 8 weeks of treatment, you're going to get massive gains in strength much faster than you're going to see increase in cross-sectional area. So those muscles are not going to hypertrophy. In fact, you can get up to 50% increase in strength in the muscle in the first month of care, but you're not going to see big bulging biceps, big bulging supraspinatus muscles. You're just not going to see those things. So you can let your patients know that's probably not going to happen unless they were going to continue to do those eccentric exercises nonstop all day for the next year. Now, when it comes to how do we see this continuum of shoulder pain, this is a slide that we had put together that I really think kind of fires home the big points of rotator cuff syndrome, because we always have insults, and people think of insults as a trauma, a specific time throwing a baseball, and that, yes, that's true. There's usually one time or one event that causes a pain or a problem, but also consider your postural stresses, sitting for a long period of time as you're doing now, sleeping for a long period of time, riding in a car. Those are also insults that add to the continuum of energies and stresses put on tissue. So a lot of times it's not one thing, it's 7 different things that have added up to now create pain when throwing the baseball that last time. So an insult, if it is great enough, if it is enough, it can cause a frank tear, rupture of a muscle, and that does happen, but very, very rare. Most of the time what we think about is that we're going to see a little bit of inflammation and healing. But what I would say is what we're going to learn in the next couple of slides is this process, this inflammation and healing, often doesn't happen. And I think part of the reason is our lifestyles, dietary, psychological, and also mechanical, the things that we do on a daily basis. So we can go through the dietary and nutritional type things that can help someone heal, which we know a big part of our population does not follow that appropriate advice. But in today's lecture, we're really just going to cover the musculoskeletal aspects of it, the postural and movement type things. Not that I'm saying that one is more important than the other, but I would rather change someone's religion than change their diet. It's just not my forte. It's not what I'm good at. I would highly recommend having somebody in your corner, someone in your town, someone in your network that does work with nutritional stuff, because it is very important to these kind of cases, which I'll hopefully hammer home that point in the next couple slides. But what we see with these patients is that they have this insult. They're supposed to go through inflammation and healing, but they have a failed healing response. And the failed healing response is partially due to they just aren't stopping the activity that's causing the insult. I've got young kids who play soccer and baseball and softball and flag football and everything under the sun that's available to an elementary school kid, and they don't stop. They'll take 15, 20,000 steps in a day, and that's just their Tuesday. So they don't ever give their bodies enough time to heal. Now, fortunately, being 10 and 12 years old, they have a little more healing potential than our 40, 50, 80-year-olds. So if I keep on taking a soccer player, let's say we have a 12-year-old soccer player, and he starts to play soccer, and he's playing club soccer, and he's kicking a ball 5 to 7 days a week. What do we see happen in a soccer player who's not skeleton mature, who constantly goes through eccentric load to the patella tendon? We see something called osgood slaughter, because that tissue just keeps on taking a beating over and over and again. Something has to fail, and we see that apophysitis. I mean, the bone isn't even strong enough to hold on to the demands that that person is imparting upon it. And we see the same thing happen in the shoulder. If we take someone who's painting ceilings, and that's all he or she does on a daily basis, well, they're constantly putting their shoulder in an abducted flex position, holding something with a long lever arm, but that's their job. That's what they have to do. Then they get a side project. They work Saturday, Sunday, they get another side project, and then you see they're working for 60 days straight. They never give their body enough rest. So we see this happen on a regular basis, this failed healing response, and eventually that tissue does give up. It stops even promoting an inflammatory reaction. Instead, it just says, it is what it is. And what do we see when that happens? We see the body lay down calcium. We see the same thing in a heel spur. We see the same thing at the AC joint with the coracoacromial ligament. We see your body say, you know what, enough is enough. You're not giving your body enough rest. I can't heal this area. Let's go ahead and throw down some bone. And unfortunately, bone is not very pliable. It doesn't do what a tendon does. It doesn't do what a muscle does. And now we have weakness in those specific areas of that tendon. And when we have weakness, the rotator cuff can no longer do what it's designed to do. So what is the rotator cuff designed to do? And I think that most people, and definitely patients, have a misunderstanding on this. Is the rotator cuff, by most of the public perception, is designed to pick the arm up, move the arm, or people in my area call it the rotary cup. The rotary cup does all this motion, and while it does have a part in that role, that's not the principal role of the rotator cuff. The rotator cuff is designed, and what we talked about in the impingement syndrome lecture, to take this ball of a bone and to pull it downward. Oh, sorry about that. To pull it downward. And if it's not pulling downward, the Teres minor, the Infraspinatus, and Subscapularis. And for those of you who don't know, the Subscapularis actually is the most powerful muscle and is is the best muscle in pulling down the glenohumeral joint and keeping it in this nice concave glenoid. But if these muscles aren't working and pulling this joint down, then it's going to start to migrate up. In fact, what we saw from the past lecture is that once you get into that 20 degrees of abduction, this is going to start to roll upward and now pinch that squishy stuff in the middle. And this is a cycle. This keeps on happening over and over again, and eventually we have tissue that is too far gone, and now it's going to start to tear. And that tearing is you're putting load across just non-compliant tissue. Now, when you look at predisposing factors, and I do enjoy reading research, and I do enjoy getting the intent behind research papers, not so much the conclusions, but when you actually look at the inclusion and exclusion criteria, you actually look at the data, you look at why they did what they did, which variables are they trying to isolate. It's often very telling to which paper that specific article is in, that specific journal is in. And a lot of times when we were doing the research for rotator cuff problems, we were in orthopedic journals. But it was interesting. Once we started going into tendinopathy, tendinosis as keywords, we started getting into different kinds of papers. Papers talking about diet, nutrition, vascularity, and and hormonal responses, things like diabetes. And I think that's so interesting because the predisposing factors to a tendinosis is somewhat the activity, but more so it's the ability to heal from that activity. And that's why a 12-year-old can go out and skin his knee, and 3 days later the skin is healed over and they're out playing again. I run outside on a scooter and skin my knee, I'm done for 6 months. I think that there's a big difference in the ability to heal, and here are the things that limit somebody's ability to heal. So obesity, issues with cholesterol, there's of course always a genetics type thing associated with almost everything, but really it turns into the things that allow blood and healing potential to get to that area. Things like hypovascularity, smoking, and what we're seeing more and more frequently is corticosteroid injections. Corticosteroid injections do take away pain. They are very good at that, especially when you put in a lidocaine cocktail. Yeah, of course it's going to take away the pain. However, steroids don't allow that inflammatory reaction to happen. So if somebody has a tendinosis and you're trying to strengthen that tissue, you really need blood flow. You really need that inflammatory reaction, growth factors to come into that area to help rebuild that tissue. And if you're getting constant steroid injections, your body won't regenerate that tissue. It's similar to what we see in knee injections. So something to consider if you're looking at a patient. One thing that I think about, I'm just going to go back one, is that when you look at steroid injections and someone is going to get surgery, they're going to have something replaced, they're going to have a knee replacement, I don't get too worked up about getting steroid injections. Great, if that's going to give you some symptomatic relief, that it is what it is. Sometimes structural deficits outweigh the functional benefits of rehabilitating somebody. Sometimes they just can't get back to 100%. But if you have somebody that surgery is not on the table, then I would really avoid steroid injections at all costs. Sometimes you need a window of opportunity. Sometimes you just can't even get the arm up. And that's a situation where you need to calm things down a little bit so you can just get that range of motion going. So in that case, it's okay if you have to. But if you're looking to rehab somebody, you're looking to increase inflammation, an injection isn't going to do it. We saw this slide, this paper just came out in 2019, that once again, you're going to learn a lot about the shoulder today. Hopefully you've learned a little bit already, but we really need to make sure that, looking as a physical medicine provider, looking at a conservative approach, we really also need to look at the spine. What we know from the spine is a lot of people with asymptomatic problems, in this case, looking at the neck and the shoulder, can have shoulder pain, elbow pain, all the way down to their foot, even though they don't think the problem's coming from the spine. And I want to make that clear differentiation, is that this just means the spine is involved. The paper uses originates, and I'm not a researcher. I can't tell you one thing versus another as far as the appropriate verbiage, but one thing that we do know is that when you have irritation, you have compression, you have joints that are moving better, you will have a little less sensitivity to those nerves that can be leading to hypersensitivity down the peripheral nature of that nerve. So one thing I would say is that when you are treating these different extremity type issues, of course, make sure you look at the spine. A lot of times you're going to see things that are either primary or possibly due to peripheral sensitization, issues at the spine that are a result of that extremity type issue. So I think that one thing that we can all agree upon is look at the whole body, look at the whole person. Don't focus on one specific area. Make sure you're addressing everything that person may be presenting with. And even though like I said, as a musculoskeletal provider, I'm still going to look at things that maybe aren't in my wheelhouse. Maybe it's nutrition that has the problems with the ability to heal. It's my job to address that with the patient. Maybe it's not my job to fix it, but it's my job to say, you know what, we need to get your blood sugar in check because your ability to heal is dependent on that issue. Now, while that may not fit into my scope of practice, or at least what I do with my patients, I've got another chiropractor down the street who does functional medicine. I've got a nutritionist, I've got a rheumatologist, I've got a dietitian, whoever it is that you're comfortable sending your patients to. Because when it comes to the shoulder, when it comes to a lot of issues, patients really like to pass the blame and say, well, it is what it is. I was built this way. My mother was big boned, whatever it is. And we all know that your genetics, it kind of does load the gun. But it's your activity, your psychology, your nutrition that really pulls the trigger. So we have to really put the blame of what's going on with whatever this orthopedic condition is back on the patient. And with science and with factual information, explain to the patient and educate the patient on what we can do to solve this problem. And if we can solve it without the need of drugs and surgery, we're only going to be helping that patient because we're empowering them to get themselves out of pain. And I think most importantly, keep themselves out of pain. One paper that I really enjoyed reading was Codman's paper, and really looking at this zone of hypovascularity. And there have been past papers that have said, you know what, that's not exactly true, that there are not zones of hypovascularity. And I get that. And when you look at the Codman paper, when they did the perfusion studies, they had the arm already back and externally rotated in abduction. So it probably was creating a little bit of compression there. However, what we really want to know is, he was onto something. He saw a sign, he saw a symptom, and he was looking for an answer. And the answer that he came up with, while it may not be exactly correct, still should give us a little bit of a lesson. The intent of the lesson is, why? Why do we get these tears? Why are they in one specific spot to start with? And why do they begin to progress through that tendon and create full tendon tears? And if we can understand why that process is happening, hopefully we can make an intervention to eliminate that. In this case, what we're seeing most often is this critical zone is a site of the tendon that has the most compression. And if we're adding compression to an area on the articular side of the humerus, then that is not allowing the blood flow, causing us to do that compression, involving ischemia to the area and allowing it to heal. So taking that into consideration, is it a good idea in this case to sleep with your arm up like this? Probably not. Is it a good idea to sleep on your shoulder, on the affected shoulder? Probably not. Is it a good idea to sleep on the other shoulder when your arm is dangling to the side and across an adductor of your body? Probably not. So it's finding those things, that new information that could be causing that inability of the patient to heal, that are all the different. It makes such a big difference in patient care when we can educate them on how they are creating their own issues. Now, I don't try to pass the blame onto them, but I also like to educate my patients that listen, Bob, everything that you've been doing, the way you sit, the way you sleep, the way you drive your car, the way you work, everything that you've been doing has led to this situation. If we keep on doing those same things, this probably isn't going to get better. So I am going to be an intervention point where I can do some treatment. I can loosen things up. I can address your spine. I can get you some more inferior glide or humerus. I can give you the right set of exercises. But if you don't make the necessary changes to your habits, to your postures, then, we're kind of peeing in the wind here, Bob, that we need to make sure that what has gotten you here isn't going to get you there. It's going to take a concerted effort on your part and my part to get this done. And the more Bob understands what's going on and what I'm going to do and what his responsibilities are, create a compliant patient. And the compliant patient is based upon their needs, their wants. As far as rotator cuff strain, tendinopathy, and tendinosis, we really need to make sure we know what tissue is injured and how to fix it. So when we get into the actual rotator cuff problem, we need to know the right evaluation. We need to know the right treatment, and we also need to know the right exercise to help with that treatment. A lot of the beginning exercises you're going to see are look very similar to an impingement syndrome. These are more of the exercises I'm going to use for a tendinitis versus more of a tendinosis, where I need to actually put load and I need to manage that load to build up that tissue. So what we'll do is we'll start off and we'll go through the actual test, meaning how can I make a diagnosis of rotator cuff syndrome? What we know from Neer is that a lot of these patients have issues with shoulder impingement syndrome first that leads to a rotator cuff syndrome. So it would be at least worth looking at, is this truly just an impingement if I think I have a rotator cuff, or is this a rotator cuff tendinosis where we have weakness? So do I have pain or do I have weakness? Pain is more associated with an itis, an inflammation. Weakness is more indicative of more of a tendinosis or a tearing of a muscle where the muscle just isn't strong enough anymore. So when you're doing all these tests, we of course need to know where the pain is, but also know, is it strong, is it weak, and then where the pain is being reproduced. So the first one being Hawkins-Kennedy. What we're going to see with this patient is you're going to bring the arm up into 90 degrees of shoulder flexion, and it's about 10 degrees of adduction. I would normally be right in front of the patient, but for this lecture, we're going to move out to the side. I have her nice and relaxed when supporting her elbow, and I'm going to passively take her arm into internal rotation, and I'm effectively, and you can do this on yourself, I am impinging that area. Am I reproducing her pain or not? So when I squish that squishy stuff in the middle, being the supraspinatus, is it reproducing her pain? You're going to impinge everybody. However, if that tissue is inflamed, it's going to hurt and reproduce her pain. So with a positive Hawkins-Kennedy, I could have a possible impingement syndrome or at least inflammation in the supraspinatus. We see the same thing happen with Neer's test. So with Neer's test, passively, I'm going to internally rotate her arm as far as possible. I'm going to block her actual clavicle, and I'm going to force some impingement here, slowly bringing her arm up into full shoulder flexion, and I'm looking for reproduction of chief complaint. You can see a little grimace on her face there. It wasn't very comfortable, probably from slapping around her kids every once in a while or what have you. And this is one of those things that this is going to show, once again, you have inflammation in the supraspinatus. Now, when you get into the actual strength test, so now when we looked at empty can test, as far as the for impingement syndrome, empty can was painful. Now with a rotator cuff test, we're going to see, is it painful or is it weak? So when you do the empty can test, we'll put the arm in the scapular plane or full abduction, depending on the citation you look at. But you're going to look at full internal rotation on the arm. I keep her arm in the scapular plane, and I'm going to help support her shoulder here. Now I'm going to push down. She's going to push up, or at least resist my pushing. And we're going to look for reproduction of pain. But we're also looking for weakness. So if I have pain, I know there's a possibility of some inflammation in the supraspinatus. If I have weakness, now I have an actual tendinosis or even a partial tear, full thickness tear in the supraspinatus. Once again, when I do this test, we do it right here at 90 degrees. That's the way the test is noted in most research articles. However, what we do know about the supraspinatus is that it is actually a little bit more of a primary mover in around the 20-25 degree range. So you can also test this same pushing down motion at 20 degrees of abduction, maybe 45 degrees, maybe 60 degrees, maybe 90 degrees, because we can have tendinosis type issues in different arcs of that muscle. So don't just test it in one range of motion, test it in a couple of ranges of motion. And the reason I like doing that, and this is a little bit more of my opinion as compared to based on fact, however, when I do this, I can really explain to the patient, this is why you feel the pain only when you do certain activities. And now when I'm doing what you'll see with the eccentric exercises, if that's too much for them, it causes too much pain, now we can go into just that specific arc of motion, and maybe we can hold our arm there. Maybe we can hold a 5-pound weight, a 10-pound weight there, and do some isometrics there, just to start to build some strength, start to pull that tissue apart, create a little bit of inflammation, and also when you do isometrics, you can decrease pain. Now, when it comes to the full can, we used to think the full can is indicative of other things that could possibly be injured with the AC joint, a slap lesion. However, the full can activates the supraspinatus just as much as the empty can test. So once again, we're looking for pain or weakness. A lot of times what you're going to see is that when you're in an empty can position, it is going to be dependent a little bit more on the supraspinatus. When you rotate them into supination, as far as their forearm, when you do the full can test, a lot of times that pain is going to get better because now they can really help that motion out with their anterior delt. They're also using their biceps. So sometimes if it's just an isolated supraspinatus issue, empty can will be positive, full can will now be negative, or at least less painful. If you detect weakness, that's when you're going to go into this is possibly more of a rotator cuff tearing type issue. Now, when it comes to the external rotators, there's one great test, and I always learned it as PAT test, but hornblower sign is also another name for it. And this is looking for external rotation. And what I would recommend is when you're doing this, really try to be passive with picking their arm up. They're going to be apprehensive about putting their arm in a little bit of external rotation like this. So you want to have them be comfortable with you. Now, what you're going to see with her left arm, she's going to push her wrist into my hand. When she's doing that, she's going to feel pain. If you had a rotator cuff tear in the external rotators, being the infraspinatus or the teres minor. What I would see, and what I've seen in my practice, is when someone has their arm up and I push in, if it hurts a lot, they're going to do this. They're going to retreat. And that's where the name hornblower sign comes in, because they look like they're blowing a horn at that point. But you're looking for reproduction of pain or weakness with this case. Now, the subscapularis is a little bit more of a difficult muscle to test, and the reason it's difficult to test is because of its orientation. On the front side of the scapula, going around and inserting on the lesser tuberosity, it just is in multiple ranges of motion. So what we do is we test this with 3 different tests, and they're very easy to do. The first one being the belly press test, and what I'm doing is trying to pull her hand off of her belly, and when I do that, does it reproduce her pain? So she's putting her hand there, and I'm trying to pull it away from her. I'm supporting her just because when you are pulling her forward, you don't want her to actually to pull her entire body forward. So I pull her with, or stabilize with, in that case, the right hand. You can also do the bear hug test, and the bear hug test is going to be very similar, but now she's going to have her arm a little further, putting her arm a little more flexion, and I'm going to do the same thing. I'm going to pull as she resists, and we're looking for reproduction of pain. When you're in these positions, the subscapularis and even the biceps are really holding on to that anterior stability of the shoulder, and a lot of times can be reproducing or pain if they're involved. So after we get done with the bear hug test, we go into the lift-off test. And the lift-off test is probably the most popular test that we're going to see for the subscapularis. And we could also possibly look into lag signs, which I think are very beneficial, but there's just not a great amount of evidence on the lag signs. The evidence is out there is good. However, for right now, this seems to be the most popular one. So lift-off test is a very easy test to perform. And what you're going to do with the lift-off test is you're going to have them put their arm in a position where they're probably not going to like it, which is full internal rotation there. And then she's pushing into my hand. And when she's pushing into my hand, that internal rotation is really isolated to the subscapularis. So if you see any kind of pain, provocation with the patient's face when you're looking at that, or also weakness upon them pushing on your hand, that's a sign of some subscapularis involvement. It's always good to test these things bilaterally. Now here's probably one of my favorite tests, and this would be a lag sign. This is for the external rotators, which are the Infraspinatus and Teres minor. There's also one we can do for the internal rotation, which would be the internal rotation lag sign. But this one does have some pretty good evidence on it. And what the external rotation lag sign, the sensitivity is in and around the 98% range. For a tear within the infraspinatus and supraspinatus, that interval is a common spot to have a tear. I'm going to bring her 20 degrees of abduction. I'm going to fully externally rotate her hand. So I'm going to activate those external rotators. I'm going to take her as far as I can, and it really will become a little uncomfortable, and have her hold it there. And if she tries to hold it there and those muscles have a disruption in those fibers, then that would be positive for a rotator cuff issue. So someone who has this is very, very sensitive for a tear in that rotator cuff interval, which is the second most common spot to have a tear within the rotator cuff. So this is there's only a couple papers on this. However, the papers do look promising. It's always good to have an idea of what you're looking for. And this is one of the things that challenges all chiropractors, is having an idea of what to look for. So a patient's going to come in and they're going to have a certain presentation, a certain history, and it's our job to decipher what's important and what's not important. And when it comes to the shoulder and looking for rotator cuff tears, Merlin Walton did a very good job of developing a clinical prediction rule to figure out, does this person have a full thickness rotator cuff tear? And the reason they were interested in a full thickness rotator cuff tear is a lot of these people do go on to have surgery. So can we look at a population just during the history and during their orthopedic exam and say, these people probably have a full thickness rotator cuff tear? These people probably are going to find their way to an MRI machine at some point in their life and probably are going to be offered surgery. And the idea is to at least give an accurate prognosis. That does not mean they can't go through a conservative, trial of care. It just means that these people are at increased risk to having a problem and possibly need to be, educated in that. So when it comes to the rotator cuff tear, most of these people are above the age of 60. And whenever we see rotator cuff issues in people over 60, it's almost more common than uncommon. And definitely when you couple that with changes in posture and activity level and jobs, we see this much more frequent in different demographics. But over the age of 60, your chance of having a rotator cuff tear is pretty much the exact same as your age after that point. So as far as the orthopedic test, they can have a positive empty can test, meaning weakness when you do that, the empty can maneuver, weakness in external rotation. So number one spot for having a rotator cuff tear would be identified with empty can test. Number two would be the external rotation. And you can do the hornblower sign or do the last test that we saw, which was the external rotation lag sign. I think both of those would be more than appropriate. And the last one would be positive signs of impingement. And I think that that's really going back a step and saying that Not only do they have weakness in the muscle, but they've already gone through that stage of impingement, which we saw in the impingement lecture, and we also saw at the beginning of this lecture. So Neer's and Hawkins would be positive, and that's when you're actually squeezing, compressing that supraspinatus tendon. It's giving you some pain and discomfort. Keep in mind that it's just pain and discomfort that is localized. It's not radiating down the arm. It's not doing anything else. So if I had these 4 things that are positive and I go through my exam, that I could still do a trial of care. However, I would educate this person just a tad different than other people. And I would say, there's a pretty good chance you have a partial thickness or a full thickness tear within whichever muscle it might be for that patient, and educate them on that. I said, listen, there is still a very good chance we can get you out of pain and get you back to your normal activities. Unfortunately, there is a structural deficit in those muscles. So we're going to get you as good as possible. Let's give it 2 to 4 weeks and see how good we get it, and hopefully avoid having that conversation with an orthopedic surgeon. The eccentric exercises, this one more for the scapular stabilizer, serratus anterior, lower middle trap. What I'm going to have the patient do now is have the arm above her body, and she's going to take advantage of gravity and a heavy weight, and she's going to go maybe a 5 to 7 second count down, and she's keeping her elbow straight, and thereby using the external rotators of the glenohumeral joint and also the scapular stabilizers to prevent or resist that motion. So now we're eccentrically loading the posterior part of the shoulder and hopefully strengthening those muscles. We really want to use a weight that's difficult. This should not be easy, meaning after 3 sets of 10 repetitions, she should be done. If she can keep on doing more, we're just using too light of a weight. Bump it up a little bit. But don't bump it up too far too fast, and don't start with too heavy of a weight. You want quality, not quantity. So with a female, I normally start around maybe 3 pounds, possibly 5 pounds, depending on her strength level. A male, not a whole lot higher. We'll start with maybe 7 to 10 pounds. These are very small muscles. They're not big, strong muscles like the biceps or the hamstrings. We want to make sure that we're doing the right motion first. The common issue that I'll see, and I'll just show it to you on the next slide, is that when they're doing this exercise, they're going to elevate their shoulder, and they're going to kind of cheat with those shoulder muscles, and that's what we don't want. They're showing their compensation. So for this one, we're going to do the eccentric strengthening for the external rotators specifically, this being the Teres minor and the Infraspinatus. And so when she's doing this, she's going to slowly prevent this internal rotation, thereby eccentrically loading the external rotators. Once again, the 5 to 7 second count down, and she's going to go all the way down, and just to hopefully load the muscle up as much as possible. We're going to avoid the concentric motion and just do the eccentric motion. So going down. Once again, these muscles aren't very big. If you've seen any kind of a shoulder surgery, we're talking about 2 ballpoint pens next to each other. They're very small muscles. So the cross-sectional area is not a lot. When you go to eccentrically load them, we're really trying to isolate those muscles. So it wouldn't be realistic to have 30, 40 pounds on these kind of patients. Possibly a professional athlete, but not in our normal public. So we don't want to go too far too fast and injure somebody. We can also do the most common eccentric exercise for the shoulder, which is for the supraspinatus. One thing to keep in mind, though, is when you're doing these exercises, I have her internally rotated to activate preferentially the supraspinatus. Some people might have some difficulty with that. And if they do, then you can go ahead and not go up quite as high. Maybe start at 90 degrees, not all the way up at 150, 160 degrees. You can also consider having the arm in a little more internally rotated position, or even fully externally rotated. It will substitute some of the delt and some of the biceps in there if you don't have the arm in full internal rotation, but that's okay. We just need to get them using the muscle, having good posterior tilt of the scapula, teaching them good posture, grow taller when they're doing that. To have somebody do this exercise and their head's forward and looking like this, they're really already in compensatory patterns. So we really want to make sure when we're doing these exercises, we start off in a good position, a good posture. Now, once again, 3 sets of 10 repetitions, once, maybe twice a day. If they have or suspected tendinosis, partial tearing, full thickness tearing, we want to be very careful, but we would expect to see 2, 3, 4 out of 10 pain because we're putting tensile stretch across an injured tissue, trying to rebuild that area. If you you get pain that's higher than that, that's a stop sign. If you get radiation of pain or paresthesia extending down the arm, that's a stop sign. If you have pain lasting more than 24 hours in the shoulder, you did a little bit too much. It's not a stop sign, but it's more of a yellow light that we need to back off the weight just a tad so we can hopefully not promote any kind of excess inflammation in that area. Because what happens is your shoulder is going to start playing chess. This is my daughter playing chess with me. We play chess all the time, and what I have figured out is that she will sacrifice all of her players for one pawn. She doesn't care. She just wants to get one of my players. She will always sacrifice whatever it takes to get one of my players, and that's how she chalks up a win or a loss if she can get one of my players. And that same thing happens in the body as far as in compensation. We'll always use these strategies to achieve a goal. And when we're trying to pick up our arm, we will figure out a way to do that. Healthily, people will just be able to pick up their arm. People, when there's problems and there's issues as far as a rotator cuff, they're going to use alternate strategies. They're going to sort of pick up their shoulder, or they're just going to stop using their arm and use the other arm. And these compensations, these strategies are detrimental to the end result, which is, our health and well-being. So we want to make sure that we identify those compensations and we look for the strategies that person may be using, and then that's what our rehab is based upon. Our rehab is essentially just showing the patient what they didn't think they could do. So we need to make sure that if they can't pick up, the milk in the refrigerator, we show them ways to make that happen. A lot of times what you'll find is there are certain things that you can do even within a treatment visit to help people along that process. The rehab doesn't have to always be just exercises. It can be advice. So if you look at the shoulder, your shoulder becomes exponentially more unstable as you bring it into abduction. So if you have somebody that's reaching into the refrigerator out to the side versus someone who's reaching the refrigerator straight in front of them, that's a whole different ballgame. Keeping your elbow close to you with your arm at your side is much more stable than not. Your shoulder is also much more stable after you retract and posterior tilt your scapula, having a firm base of support. So there's a lot of different strategies you can teach your patients that's part of their rehab, not just blindly following some exercises. As far as other things that we can do, I don't think surgery is a bad option for anyone, but just the right people, not everyone. I think that surgery is one of those things that can help with symptoms, normally not because of the surgery, mostly because of the recovery time, as they can't use their arm for another 4 to 6 weeks, if not months, depending on the surgery. So that's a big part of the pain response. But once you actually surgically repair and you suture together a tear, it can help with the final tear size. However, a reoccurrence is still there. I mean, these people are still going to have rotator cuff tears. It just may be in a different spot now. So yes, we can help with symptoms. Yes, we can help with that specific tear. But if we don't fix the initial problem, job, posture, activity, sport, it's going to tear someone else. Your body will always find the weakest link. So we need to make sure that we understand those compensations, those strategies, the sleeping position, the way they throw the arm in their slot angle, the way they use their mouse, the position of their workstation. Those are the kind of things that can help keep somebody out of pain and prevent this from happening again. Otherwise, people fall into this cycle of trying new things to get rid of their shoulder pain. People will pour endless amounts of money into fixing problems. But very rarely will pay any money for you to take something out of their life. It's kind of like a diet. People will pay endless money for supplements, but nobody will stop drinking Diet Coke. The same thing happens with the shoulders. We'll pay money for injections and PRP injections and steroid injections, but we won't stop the things that actually cause that pain and inflammation to begin with. Now, sometimes we can't. I'm a chiropractor. I work for a living. I need to see patients to pay my bills. I get it. I understand that. However, we have to make sure that we're trying to eliminate the things that cause compression and excess tensile strength, because this is not a good strategy to alleviate symptoms. Now, corticosteroids will alleviate pain and will take away inflammation. So if you had a tendinitis model and you did one injection and someone just did something abnormal to flare it up, that may not be the worst option. If someone has a constantly irritated shoulder repetitive steroid injections is not a good option. In fact, it's almost counterintuitive. When you have a tendinosis model, someone has a constant, chronic, reoccurring pain in the shoulder, we need to promote inflammation. We need to put tensile stretch across that muscle tendon unit. So putting a steroid in there will actually decrease inflammation and decrease the healing potential of that area and decrease the effectiveness of your treatment. Now, on the same token, we have other strategies like PRP injections or stem cell injections that put an influx of growth factors into the area. So if I had a situation where I had a tendinosis that I need to rebuild essentially with my rehab and the things that I'm going to do for it, I don't see an issue with PRP or injections or any kind of platelet injections that will help increase the inflammation and help with the healing process. Now, with that being said, I can find enough research to back up doing PRP injections versus it does no good. This is seen for every kind of modality. This is a recipe. It has to do, the interventions have to make sense. Meaning you can't do PRP injections on people with shoulder pain. That doesn't make any sense. You have to do it for the right situation, and it has to be part of a multimodal care plan. Now, what we know, and possibly one of the detriments to chiropractic, is that spinal manipulation works so well. And it works so well that we can really treat a lot of different conditions with spinal manipulation, and almost all of our patients leave our office feeling better. That doesn't mean the treatment worked, though. That just means that with spinal manipulation, through increasing range of motion, through peripheral sensitizations, we can decrease pain and improve range of motion. That doesn't mean that it's going to be a long-term solution, though. It may be part of a long-term solution. And I think for a lot of conditions, it is a part of a long-term solution. However, not in isolation. We need to consider other things that make sense. What's the principle behind this dysfunction? If I have a tendonitis, I need to think about rest, relax, anti-inflammatories. If I have a situation that's a tendinosis, I need to rough it up. I need to improve healing. So there's a lot of different situations that we can use a plethora of different treatments depending on whatever principle we're trying to treat. When it comes to MRI, when it comes to the current research, we're seeing a lot of people shy away from advanced imaging, and I'm definitely on that boat. That's what the recommendations say. So I think that that's a good baseline, but never be afraid to do imaging, X-rays, MRIs, ultrasound. If we think that it's going to benefit our patient, you need to put your clinical hat on and help with that. With that being said, though, I wouldn't jump on imaging too fast. And the reason I say that is because if we do imaging too fast and someone has a structural deficit, that's all they can put through their mind is, I have a structural deficit. This is going to be here forever. This is terrible. I can't get rid of this rotator cuff tear. And what we know is that's not true, is that there are plenty of people with tears, full thickness tears, that are asymptomatic. So just having a structural deficit does not mean someone's going to stay in pain. The same thing if you had arthritis at L5. If you're above the age of 35, so does everybody else. That doesn't mean you're going to have a pain or a problem. Now, with that being said, is that if I do suspect a full thickness tear, if I do suspect this person may need surgery, then yes, I'm still going to try a trial of care, but if it's failing, then that's a good time to jump on some excess imaging to see what else can be done for this patient. One thing that we know and that we attempt to correct as chiropractic physicians is posture. And posture is not one of those things that's easy to change. If I was going to change a habit with somebody, it takes months to do, especially in a musculoskeletal habit. What I tell my patients is, hey, Johnny, are you right-handed or left-handed? Right-handed. Johnny, I want you to start brushing your teeth with your left hand. And let me know how long it takes you for that to feel normal. And what the literature says, which Johnny will never figure out because he'll never do that for 6 months, is it takes 4 to 6 months to start a new habit. So posture takes a long time, whether it's breathing mechanics, whether it's just pure posture. It takes a long time for someone to regroove these motor patterns. However, with the shoulder, I tell people to get taller. So if you can imagine a string on top of your head, is that you're trying to pull up on that string. The odd part about that is when you do that, you really don't activate one muscle. Whereas people that try to get into a better posture, and we'll see that with military postures, they really try to activate muscles to have a better posture. increases compression, and it's not a good strategy. I think that growing taller really works the postural muscles, puts the ears over the shoulders, and puts a lot less stress on the back part of the neck muscles as compared to activating the front part of the neck muscles, the longus colli and capitis. So what we do know is that if we can improve thoracic spine extension, they can have less kyphosis, that we can really even help with impingement syndrome. And also manipulation. One thing that we know better than most is manipulation helps because we can get into now thoracic spine extension, which can help with subacromial space and a resultant impingement syndrome.
Thank you for watching this webinar. It's always a pleasure putting together things that are only 1 hour long. However, for completion, we can't include everything. If you have any other questions, you want more information on any of the tests, the treatments, or the exercises, please contact me. My name is Brandon. Email's brandon@ChiroUp.com. I'd be happy to answer any questions. And once again, thanks for watching.